There are some interesting efficacy results to this study. First of all, the response rates, the overall response and complete response rates were the same in both arms. Nevertheless, the important endpoints, the time-dependent endpoints, were quite different. There was a significantly longer progression-free survival, time to next treatment, and most importantly, there was a survival advantage with the bendamustine obinutuzumab arm compared with the single-agent bendamustine. So despite the fact there's a lower dose of the traditional cytotoxic, the addition of the antibody makes it a much more effective combination approach. Even though you're comparing a combination of two agents with the single drug, there really were no major safety signals in this study. Of course, there were more infusional reactions when you give an antibody. We expect that. There was a bit more neutropenia, but no difference in neutropenic fevers, no difference in infections. And in fact, there was more thrombocytopenia in the bendamustine alone arm. All the other toxicities were reasonably comparable. So this increase in efficacy was not complicated by much difference in the toxicity profile. Well, we're in an interesting time with indolent lymphoma treatment. I think this regimen is an excellent one for patients who received rituximab alone, or chemoimmunotherapy with rituximab, or chemotherapy or chemoimmunotherapy followed by maintenance, because in all of those prior treatment groups, the combination was advantageous. Now, in the United States, more patients get bendamustine rituximab up front than any other combination. But we're starting to move into more targeted approaches and moving some of those up front. So I still think there is the opportunity to use this combination in patients who failed R-CHOP initially, failed rituximab initially, or failed some other form of biological non-cytotoxic approach initially. I think for the foreseeable future, this regimen will fulfill the niche for rituximab-refractory follicular and low-grade lymphoma, because when you look at the data in progression-free survival, time to next treatment, and overall survival, it was significantly better not only for the follicular lymphoma patients, but for the group of patients overall. I think the results of the study should clearly change practice and should become the standard of care for patients who are rituximab refractory to frontline therapy. We are currently in an era where we are moving away from traditional cytotoxic therapy, from chemotherapy, chemoimmunotherapy, to more targeted approaches, to more individualized, personalized approaches. We have countless new agents that target the cell surface, monoclonal antibodies, antibody-drug conjugates that target intracellular pathways, whether it be PI3K, whether it be BTK, SYK, BCL2, and we have a number of drugs that are targeting the microenvironment. Lenalidomide, the PD-1 and PD-L1 and other checkpoint inhibitors. And various combinations and permutations, doublets and triplets of these drugs are widely in development in clinical trials. And it is highly likely that in the next few years that we may see a change in frontline therapy. I think one regimen that may alter our approach is the R-squared regimen. And we initially developed R-squared over a decade ago. And because of the data in relapse patients, and now two studies, ours and Nathan Fowler's study in the upfront setting, it stimulated interest in the relevance trial, which was R-squared, rituximab, lenalidomide, versus R-chemo. And if that study is positive, I think it will totally change how we treat follicular lymphoma in the front line. But we still are going to need novel approaches in the relapse setting. So for now, bendamustine obinutuzumab is a great therapy for rituximab-refractory patients. But we are developing newer non-chemotherapy approaches, and I think that's the future of follicular and low-grade lymphoma.